Good afternoon, Dr. Francis Furio. It's nice to see you.
Hi, good afternoon. Thank you for having me.
So today we're going to look at forensic social work and specifically suicide risk assessment. And I know that you have worked extensively in prisons. I believe you were in Soledad, which is local to Monterey Bay. So I look forward to hearing a little bit about that experience. That's a really unique niche for social workers.
Yes,
And I will turn it over to you to talk to us today about your hands-on knowledge.
thank you so much, Dr. Otabi. So yeah, I'm Dr. Furio. My pronouns are she, hers, and I'm very excited to be here speaking with you about forensic social work and suicide risk assessment. I'm very passionate about forensic social work, and I actually spent my time pursuing the licensure in social work while working at the correctional training facility in Soledad, which is a level 1 and 2 prison. All right, so today's agenda, we're going to talk a little bit about forensic social work and what that is and what that looks like. We'll then talk a little bit about what the suicide rates are looking like in correctional facilities, some of the stats and data, and then move into a discussion related to suicide risk assessment in prison settings and what those look like. So what is forensic social work? Forensic social work has been defined as the application of social work practice and principles to issues relating to law and legal systems. It really includes social work practice that in any way relates to civil or criminal legal issues or litigation. And forensic social work happens at all levels, really, at the micro level, at the meso level, at the macro level. And the functions of social workers within the forensic profession could include, child custody and related issues, advocacy, program development, policy analysis and research, micro clinical practice within correctional facilities, like providing psychotherapy to inmate populations, including diagnosis and treatment and crisis intervention, which is what we're going to be talking about today. Also making recommendations in the context of court proceedings and teaching and training and supervising in areas related to forensics. Today, I want to focus more on that micro level of social work practice in forensic settings, and more specifically, clinical social work and crisis intervention within prisons. Now, as a group, the inmate population carries more risk than the non-inmate population, including higher rates of psychiatric disorders, substance misuse, violence, social dysfunction, childhood adversity, and also medical disease and morbidity. Suicide prevention has been described as a societal and complex public health problem. And each suicide is really a devastating tragedy with a significant impact. Social workers play a really important role in keeping people safe within correctional facilities, especially in regard to suicide risk assessment and safety planning. In fact, one study actually found that mental health professionals practicing in corrections indicate that conducting suicide risk assessments is among the most important aspects of their job. As this quote states, suicide risk assessment is a very important part of forensic social work. And while it can be a difficult task, difficult work that requires really detailed assessment and these critical judgment calls, I do believe that it can also be one of the most rewarding opportunities that we get as social workers in these settings. So in 1990, the California Department of Corrections and Rehabilitation, or CDCR, began tracking the annual suicide frequency rate. Now, the most recent report and the most recent data that's available to the public is from the year of 2020. So we're going to look at some of that here. Now, in 2020, there were 31 total suicides within CDCR, or the Department of Corrections and Rehabilitation in California. That's a rate of 27.3 per 100,000. Now, the 2020 rate was actually the first decrease, the first year of decrease after 5 straight years of increases within CDCR. And we can kind of see that here at the end of this graph, right? In 2019, the number of suicides was actually the highest since 1985. The rate reached 30.3 in 2019. And then again, in 2020, we saw a decrease down to 27.3. To put that into some perspective, when we look at like national suicide prison rates, based on data from the Bureau of Justice, the rate of prisons nationwide is about 26 per 100,000. So again, the national average is a bit lower than what we're seeing in California prisons. For another comparison, if we're looking at non-incarcerated adult men just living in the community in California specifically, in 2019, their rate of suicide was 22.6. And again, the California rate is at 27.3 in 2020, so definitely higher within the prison settings. Now, in the US, suicide is actually more prevalent in jails than it is in prisons. The rates of suicide among adult males in the United States and those in jails and prisons are shown here. Now, one potential reason or hypothesis for why suicide rates are higher in jails than they are in prisons could be due to what is often referred to as the shock of confinement, right? Like when a person is arrested and when they're in jail, like suddenly they've been stripped of their job, their housing, they may worry that they've suddenly lost loved ones, their families perhaps, and they don't know what the future will hold, right? Because they're still going through court proceedings. They haven't yet been sentenced. And what the data shows is that many of the folks who commit suicide while in jail actually do so before they've been convicted at all. Now, it's a common belief that suicide increases around the winter holidays. However, data from the CDC showed that spring and early summer typically have higher number of suicides. And the long-term numbers that we have from the Department of Corrections in California show similar trends to this. So in 2020, November had fewer suicides compared to the 10-year average that we can see. So the blue is 2020, the red is the 10-year average, while in December and January had more. But again, these numbers will likely continue to fluctuate around the long-term averages. This figure here shows different methods of suicides from 2015 to 2019, as well as throughout the year of 2020. Hanging is consistently the primary method of suicide that we see within prisons, almost this like culturally scripted method of suicide within that environment, followed by lacerations, and then we can also see asphyxiation, and then also some stabbings that occurred. Individuals who do die by suicide often experience precipitating events, right? Or these significant conflicts, whether they're interpersonal or these significant life events in the weeks or the months that are leading up to their death. Mental processes like symptoms of a mental illness, negative life events, just the ongoing collection of different psychosocial stressors, like these absolutely can also play a role in suicide. Now here in this slide, you can see the frequency and the percentage of the total precipitants of suicides that are listed or suspected by the suicide reviewers within the Department of Corrections and CDCR. Now, in many cases, the precipitants are not completely clear or they're not definitive, right? And rarely can one precipitant be identified as like the sole primary reason somebody ended up dying by suicide. Instead, it's often this really complex combination of all of these different, like multiple factors and pre-existing vulnerabilities, which we'll talk more about. But in 2020, mental health symptoms were identified as significant in 15 of the 31 suicides. Safety concerns were also noted to be a significant factor. Safety concerns could be due to a variety of reasons within prison settings. Oftentimes we see safety concerns among folks that have been charged or convicted with a sex offense, those that have dropped out of gangs, ex-law enforcement. We also can see on this table that medical illness and chronic pain and medical disability contributed to 8 of the suicides. So that's 26% of the suicides in 2020. And then also, another big risk factor we're seeing is new criminal charges, getting disciplinary actions within prison settings, having additional time added on to your sentence. Bad news at a board of parole hearing, right? A denial for parole, for example, and just other custodial issues are also contributing to some of these suicide deaths. So suicide risk assessments are this process of inquiry and this process of data collection that often includes interviewing the person that's receiving services, reviewing any relevant notes that you can locate or documentation that's available related to the person, conducting as many collateral contacts as you can. So that might be like making a call out to the housing officer to see how this person is doing in the housing setting, maybe talking to other officers on the yard, talking to other staff on the multidisciplinary treatment teams like psychiatrists or psychologists, for example. And then putting together a case formulation or your own hypothesis about what's going on, completing a risk assessment, when then making a judgment of risk or a risk formulation, which we're going to talk more about. And then that all really informs treatment planning and any clinically indicated next steps that you might be taking, whether that's admitting someone to a hospital or pursuing like a safety plan, a collaborative safety plan. Listed here are scales and measures that are commonly used in the process of suicide risk assessments. So some of these measures include like the Beck scale for suicidal ideation. This is a 21-item scale that assesses for suicidal desires and attitudes and plans and behaviors. The Beck hopelessness scale. This is a 20-item scale that explores hopelessness, explores pessimism about the future. There's the ASIQ, or the Adult Suicidal Ideation Questionnaire. It's 25 items and is really focused on the presence of suicidal ideation within the past month. The Suicide Risk Assessment Checklist, which includes a number of items really further exploring suicide risk. There's the RASQ, or the Reasons for Attempting Suicide Questionnaire. And this measures not only like internally motivated reasons for suicide attempts, but also potential externally motivated reasons for suicide attempts. And then the two that we're going to talk more about today are these last two on this slide, the Columbia Suicide Severity Rating Scale and the CAPSIP, or the Culture and Protective Suicide Scale for incarcerated persons specifically. So the Columbia Suicide Severity Rating Scale is something that's commonly used within prison settings and when completing suicide risk assessments. It's a measure that's used to identify and assess individuals that are potentially at risk for suicide. It measures the severity of ideation, the intensity of ideation. It measures behavior and lethality that's related to suicide. And these questions can be very useful to explore the details of a suicide attempt or an incident of self-harm, perhaps. Now, questions exploring suicidal ideation include, have you wished you were dead or wished you could go to sleep and not wake up? Have you had thoughts of actually killing yourself? Have you thought how you would do it? Have you had the thoughts and have had some intention of acting on them? And have you started to work out the details of how to kill yourself? And do you intend to carry out this plan? So really exploring, again, the severity of the ideation, but moving as well into assessing for, does this person have a plan in mind? And do they have intent to carry out that plan? Listed here are some questions looking at frequency and intensity, like how many times have you had these thoughts? When you do have these thoughts, how long do they last? If you try to stop thinking about killing yourself, are you able to? Are there things that you can do to stop these thoughts? What sort of reasons do you have for wanting to die? Questions looking at lethality and intentions, including, have you made a suicide attempt? What did you do during that attempt? Did you want to die when you did this? Have you ever perhaps made an attempt, but you were interrupted by someone or something? Maybe you stopped on your own during an attempt for some reasons. In this slide here are some examples of items from the Culture and Protective Suicide Scale for incarcerated persons, or AKA the CAPSIP. Now, with this scale, clients are asked to respond to just different items, and some examples are listed here. I have a family that cares for and supports me in or out of prison. I can live a meaningful life in or outside of prison. My religious group prohibits suicide, or how I was raised. If I die by suicide, that means I'm going to hell. I know I have something to offer others, or I'm able to help maybe other youngsters or folks that are new to prison coming in, and that provides me with meaning. So there's all of these different statements really looking at cultural and protective factors. And then the client is asked to rate their level of agreement with these different items. So now moving into a more specific conversation about risk factors specific to the inmate population when we think about suicide, also some warning signs to be looking out for, and some protective factors to consider. Effectively assessing for suicide potential in correctional facilities and populations is really this multi-step process that includes consideration of all of these things. And ultimately, a clinician or a social worker makes a determinant of risk using a really structured process. And decisions are really closely guided by these risk factors we're identifying, these warning signs that we might be identifying, the protective factors that we're exploring and understanding. Now, a risk factor is defined as a measurable characteristic, variable, or hazard that increases the likelihood of the development of a bad outcome. They are most often identified from the research, right? Now, listed here are some risk factors for suicide to consider related to this population. So in prison, safety concerns are a big risk factor. We saw that earlier when looking at that table that was showing precipitants for suicide in prison settings. Ineffective coping, a history of multiple suicide attempts. So research has actually suggested that after a person makes a second attempt, their risk of further future attempts continues to substantially increase. Another risk factor is a history of childhood trauma. So really the information that is explored in the ACE scale, for example. So child abuse, neglect, witnessing domestic violence within the family, perhaps a family history of suicide. That's also a risk factor. Having the persistent suicidal ideation, desire, intent, or preparation. Current or impending triggers. Poor connection to sources of support. A lack of protective religious, cultural, familial, or personal beliefs about suicide, disciplinary violations, a receipt of bad news, single celling, so being in a cell by yourself instead of having a cellmate, right? So being alone in a cell puts you at a higher risk of suicide than if you were to be celled with another inmate. Another risk factor is those that have a commitment offense that's murder, or some kind of violent crime. Suicide risk is much higher in people who have perpetrated serious acts of violence or been exposed to violence. Long sentences, especially like life sentences or life without parole or LWOP sentences, having that pre-adjudication status, segregated housing, negative staff interactions, a first prison term. It makes we see a higher risk during a first prison term, and also just being new to prison, the risk is higher. Here in this slide is a really helpful mnemonic provided by the American Association of Suicidology to assess for warning signs. Doing so is a helpful way to gauge for immediate action that might be needed, and it really adds to helping us make those judgment calls about risks and treatment planning. The mnemonic is called "Is Path Warm?" and we'll go through each aspect of this. So starting with the I, ideation, we're looking for active or passive suicidal ideation, right? Substances. So are there substances on board? Is this person currently under the influence of any substances? Are we seeing any purposelessness, right? Is there psychic pain? Does this person have reasons for living and dying? Maybe the client is voicing a lack of purpose in life or a loss of purpose in life. Maybe they don't see a sense or a reason for continuing on in life. Anxiety. This can also look like agitation. So does the client appear anxious? Do they appear agitated or able to sleep? Is the client maybe telling you that they're unable to relax, for example? The T is trapped, really looking at the ineffective coping. Like, does this client believe that maybe there's no way out of their current situation? Do they believe that death is perhaps even like preferable to the pain that they're experiencing in life? Does the client feel like this is their last choice, or that they don't have other choices related to this? H for hopelessness. This is a really important research-based indicator of suicide. Does the client have a negative view of themselves? Do they have a negative view of themselves, others, and their future? Does the future appear hopeless? Do they have very little hope for maybe positive changes that could happen in the future? Next, the W, withdrawn. Does the client indicate a desire to withdraw from others in their life, from loved ones, from family, from friends? Are they already starting to withdraw or perhaps isolate themselves? The next A, we're looking more at that anger, the agitation. Is this client expressing maybe feelings of rage? Do they have uncontrolled anger? Are they acting out perhaps in some ways? The R for recklessness, which is really looking at, impulsiveness. The M for mood lability, so looking for those sudden shifts in moods, maybe unpredictable moods. Is the client reporting that they're experiencing these big dramatic shifts in moods or states? And one thing to really note too about these risk factors, about the warning signs, risk factors may not apply to every person. So for example, when we're talking about bad news is not an objective fact, right? It's more of a subjective event. The impact of bad news can vary a lot depending on the person, depending on their unique history and their unique psychology and what that means to them. So data about the presence of these risk factors or the absence of these risk factors, yes, it absolutely needs to be collected, but it's also only the starting point. To really gain an understanding of someone's risk for suicide, we have to learn how someone uniquely responds to these risk factors, what they mean to that person, how they impact that person's life. So it's really helpful to go beyond the forms and explore really the qualitative nature of the risk factors that are relevant to our clients. Here are some examples of protective factors that may buffer the risk of suicide in prison settings. They include interaction with external communities, family ties and having social supports, self-efficacy, ambivalence about dying, future orientation, so plans for the future, that therapeutic alliance, so having that rapport and that therapeutic relationship, spirituality or religious beliefs, those feelings of connectedness with others, a desire or will to live, and a general sense of purpose in life. It's important to, discuss these protective factors and the quality of them. And then also, we can, in treatment planning, try to strengthen them, try to increase them. That being said, it is important to note that the value of these protective factors, it does begin to fade as the risk for suicide increases, right? So this could be due to someone becoming so preoccupied internally that, these buffers are unable to get through, they're unable to do the buffering. As the person becomes more preoccupied, as they continue to ruminate maybe on death and on suicide, their ability to access and utilize these different resources could absolutely decrease. So that being said, we can't rely solely on protective factors to reach a judgment of risk. Instead, these factors really play an important role in supporting the individual, and they can serve as moderators to some historical risk factors, like childhood adversity, for example, or chronic illness or mental illness. So risk formulation ends up being this pretty complex task, as you can see, that integrates all of this knowledge and data that you've collected related to risk factors, the client's history of suicidality, what fuels suicidal desire for that person specifically, what a suicidal crisis looks like for that individual, and also what's going to help bring that unique person out of crisis. We can't understand a patient's current risk of suicide without understanding their risk factors, their vulnerability to suicide. And then we can't really intervene appropriately unless we understand what fueled their desire for death, how this started. We also are going to have trouble recognizing when a suicidal crisis happens if we don't know what a suicidal crisis looks like for our clients, unless we've already discussed with that person what a suicidal crisis looks like for them, what that mode looks like for them. So an adequate assessment includes both data collection and judgment of risk with justification. This data collection and suicide risk assessment, it informs our individualized crisis management, it informs safety planning and goal setting. This process is directly tied to treatment planning and to our clinical decisions. It helps us decide whether to admit to crisis bed or not, whether there's a need to make a change to a treatment plan, whether you need to have like a possible medication consult and make a referral. Risk assessment is this process, and each evaluation, each one just provides this picture and this snapshot in time. And because you're really just getting this snapshot, risk assessments do need to reoccur pretty frequently. So crisis management and safety planning is going to include decisions related to the level of observation that's needed, whether you need to admit a client to a hospital, and also the individualized targeted goals, including efforts to decrease risk factors and efforts to strengthen those protective factors we talked about. Lastly, I want to talk just a little bit more about ambivalence. Again, those risk factors that we talked about, they apply to all inmates, yes, but each person absolutely responds uniquely, and each is going to be uniquely impacted by them. And this is one of the reasons why we have to be very curious and inquire, and also why it's really important to go beyond like the list of risk and protective factors alone when we're doing these suicide risk evaluations. Part of this includes exploring ambivalence and really looking for like, what has held this patient back from committing suicide or attempting suicide already? Can the positive side of that ambivalence that they're experiencing, can that be harnessed and strengthened? What protective factors at this time are most intact, are most relevant, and how do we strengthen these? What do we know historically about high risk states for this individual? And how can we then intervene, right? And this is where having those conversations about past attempts can be really useful and helpful. And then finally, what should we be monitoring? What should we be checking for and observing? Every safety plan should include, what the patient is agreeing to do and what others are going to be observing in the patient at these different high risk states. These questions all really aid us in understanding the case in a way that can help us formulate risk and manage risk. We want to learn both sides of the person's ambivalence. We want to understand their reasons for dying and their reasons for living. And while we absolutely empathize with the negative, we have this opportunity to accentuate the positive. Listed here are just some recommended organization websites for you to check out. If you're interested in learning more, we have the American Association of Suicidology, the American Psychiatric Association, and the California Department of Corrections and Rehabilitation, who will likely be releasing a report at some point soon on the data and statistics for suicides during the year of 2021 within CDCR. All right, any questions or comments?
Well, I guess that's up to me.
Yes.
So when you were working in the prison setting, were you able to do like a comprehensive case management plan so that you knew inmates that well? Or were you working like for everyone, or were you working with inmates that had been identified as needing extra support?
That's a great question. So every client that I worked with during the years that I was working for the Department of Corrections and Rehabilitation, for every client that I saw, I also completed a suicide risk assessment. And that's just part of like the standard of care practice within the Department of Corrections. Now, that being said, there are different levels of care. So there are some folks that are just getting the suicide risk assessments on like a semi-regular basis, like every 90 days, for example, or maybe even just once a year if they've been determined to have a low risk of suicide. But then there's also clients who are receiving suicide risk assessments much more frequently. For example, when someone is released from like a crisis bed situation, or they've recently been hospitalized after a suicidal crisis, they're going to be receiving much more one-on-one monitoring and follow-ups that include suicide risk assessments and ongoing safety planning as well.
So what was your caseload on average in the prison setting?
So at a lower level of care, the caseloads can be anywhere from 60 to 80 people on average. At a higher level of setting, so if we're looking at more severe mental illness, higher acuity, the caseloads are going to go much further down and look more like 15 to 20. But to give that a bit more perspective, if you're working at a higher level of care, you're seeing your client every week. If you're working at a lower level of care, the expectation is that you're seeing a client at least once every 90 days. So a big difference, a big shift there in the level of monitoring.
And how frequently would you really come into contact with somebody you're really worried about, so that you're really moving into crisis mode with related to suicide?
I completed suicide risk assessments, I would say, if not every day, most days. Admissions to hospital settings, probably once every quarter. I would say maybe once every 90 days. There's the level of acuity where I'm not maintaining this person at this level of care. We're not going to be creating a safety plan here. Instead, it's clinically indicated that they need more of like the one-to-one emergency level assistance and care.
So the vast majority of the work was really focused at that case management level, where you were creating a safety plan with the prisoner and
Yes.
negotiating for how they were going to cope.
Yeah, and it really gets to end up being this really cool collaborative process, where you're creating the safety plan together, identifying over time, like what's working the best for this person. And it focuses really on internal coping first, like when this person starts to notice those unique warning signs for them, which again are going to look so different for everyone. But when they start to notice those warning signs, like that they have this go-to plan of things that they can do, of people that they can contact or reach out to, of those like emergency resources and services that they can turn to in the case of an emergency or a suicidal crisis. So that becomes a very like empowering experience for everyone involved.
So I think one of the things that struck me, even from one of the pictures you have with a group of women with their arms interlaced, and it was
Mhm.
the idea of social support
Yeah.
and how people make, and that sense of also connectedness that you spoke of.
Mhm.
And in this class, we talk about social support being emotional support, which is the most obvious one. And then
Mhm.
there's also informational support, where people are sharing information, giving each other advice based on information.
Mhm.
Then there's instrumental support. That is, you have somebody you can go to for a small loan or for a favor that's very tangible. And then
Yes.
there's
Yeah.
appraisal support where we compare ourselves to
Mhm.
others. What kinds of are some of the unique issues around social support in the prison setting?
That's a great question. And like as you were listing these different types of support, like those are all relevant to the prison setting, right? And so I think within that population, inmates and these folks that are experiencing this lifestyle within the prison setting, like they are able to get peer support and make connection within the prison setting, other folks that are incarcerated and having similar situations. They're able to find that support in different like group therapy contexts, just in so many ways, truly in so many ways.
Yeah, it seems like there'd be lots of interesting forms of social support given some of the confines of prisons. As you said, people who are in a cell by themselves are at higher risk for suicide. So
Mhm.
that linkage with the cellmate appears to be really significant.
Absolutely, absolutely. And I think one of the things that makes prison settings kind of unique too is like we know how important that peer-to-peer support is. But then within a prison setting, there are all of these like other complex factors and things going on, like for example, safety concerns. If someone has like very significant real safety concerns, they may be less likely to share, less likely to connect or be feel less safe to have the vulnerability to make those connections with other people, right? And to share about themselves. So there's also like that added barrier then to the social connectedness.
Yeah, some unique issues.
Mm-hmm, mm-hmm.
Really appreciate your insight and your expertise today, Dr. Furio. It's really important for us to think about these uniquely vulnerable populations, and the prison setting is certainly a very interesting place to have practiced.
Thank you so much for having me. Like, what a great opportunity to come speak with you and spread the word about forensic social work. If anyone is more interested in hearing more about forensic social work, about social work within prison settings, about suicide risk assessment, like please do not hesitate to contact me. My email is listed here. But thank you so much just for your time.
Thank you.